open for questions, and we will be collecting them and asking them to our panelists towards the end of the event, but guests are on mute just to avoid any background noise. And we will also have a live Q&A towards the end where you can raise your hand. And you can find this under the participants button on the bottom bar. There'll be the option to raise your hand there. So the purpose of this town hall is to examine the intersection between racial justice and healthcare justice. These movements have long worked together before and during the civil rights era and continue to do so. Were particularly active during the passage of Medicare and the desegregation of hospitals. So today we want to highlight the racial health inequities that continue to exist and demonstrate why we need to center racial equity in our fight for healthcare reform. We're really excited for our speakers today. So we'll be hearing from Rex Tai, who's a fourth-year medical student at University of Illinois at Chicago College of Medicine, who also serves on the executive board of Students for National Health Program. Welcome, Rex. And Dennis Kosuth, who's been a nurse for 14 years. He works full-time at Chicago Public Schools and part-time at Cook County Hospital in the emergency department. And he's an active member of Chicago Health Equity Coalition, the Chicago Teachers Union, and National Nurses United. So welcome, Dennis. We also have Vidya Bashpabharathi, who is a second-year medical student at the Stritch School of Medicine at Loyola University and is a leader of their local SNAP chapter there, so welcome. And finally, last but not least, we have Mary E. Flowers, who is a member of the Illinois House of Representatives, representing District 31. She assumed office in 1985 and has for many years been introducing Illinois single-payer legislation, the most recent of which is House Bill 62. And she also serves as the chair for the Healthcare Availability and Access Committee. So thank you for joining us tonight, Representative Flowers. So without any further ado, I will pass it over to Rex for a land acknowledgement.
Okay, so let's just wait for our slides to get on screen. So yes, thank you all for sharing this space with us tonight. Before we get started, we want to just be very respectful and reflective of our history, especially for those lost and suppressed within America's nation building mythology. We should acknowledge that our medical schools, communities, and places we call home in Chicago were formerly home to the native tribes of the Three Fires Confederacy, including the Potawatomi, Ojibwe, and Odawa peoples, as well as the Miami, Ho-Chunk, Menominee, Sac, Fox, and Kickapoo, but whom were forcibly displaced via genocide, land seizure, and relocation. But they're still here among us. Chicago is home to one of the largest urban Native American communities, and they observe many important traditions that shouldn't be lost to us, especially those of us trained in Western medicine. They have centuries-long traditions of communal healing and land stewardship that kept both their communities and the lands they lived on whole. And we should find ways to amplify their teachings and find lessons that will help us heal our collective trauma and hurt amongst ourselves. So with that, I will hand it off to Vidya to lay the case for us. What's going on?
Thank you so much for that, Rex. So this is some background on the current maldistribution of access and cost of healthcare. 59% of the 28 million uninsured US residents are people of color. Hispanic and Black Americans have a significantly higher uninsured rate than whites. Over 2/3 of Black communities have a shortage in primary care providers. Hospitals are more likely to close in communities of color, the most recent example in Chicago being the closing of Mercy Hospital, which we'll learn more about later. The reason for increased hospital closings is intrinsically connected to the uninsured rate. The more uninsured or underinsured people there are in a community, the less revenue generated for the hospital, meaning less incentive for the hospital to remain open. Mercy is also one of the oldest hospitals in Chicago as well. It opened its doors in 1852. So this is obviously a great loss to the community. And we are going to focus on Illinois District 1 for this presentation to better understand some of the local health disparities in the district. The majority of uninsured in District 1 are minorities, although minorities are a small proportion of the overall population. In terms of socioeconomic status, it's clear to see that lower SES is correlated with uninsured status. The majority of uninsured earn less than 2.5 times the federal poverty line. We know that the federal poverty line is not a living wage and it's not enough to cover basic needs. And in order to qualify for Medicaid, you must earn under 138% of the federal poverty line, leaving those who earn up to 4 times the federal poverty line uninsured because they may not be able to afford private insurance and they simultaneously do not qualify for Medicaid. So we've talked about some of the social determinants that impact healthcare access. And how does this affect healthcare outcomes for people of color? One important outcome to consider is life expectancy. Black Americans live 3.5 years fewer than their white counterparts. Black Americans born in 1980 are expected to live 6 years fewer than white Americans. And the US lags far behind other heterogeneous nations in these outcomes. As you can see in this graphic, Black men are passing away at higher proportions than not only white men in the US, but also Black men in other countries as well. So here's a look at a few other health outcomes. Compared to white Americans, Black Americans are more likely to pass of chronic conditions like diabetes, HIV, heart disease, and cervical cancer. Many of these conditions have screening protocols in place and can be caught early on with increased access to healthcare settings. When it comes to motherhood, Black moms are more likely to lack prenatal care and are at least 3 times more likely to die from pregnancy-related complications. And perhaps most tragically, Black babies are more than twice as likely to die than white babies. It's clear that most, if not all, of these statistics are preventable. Many of these poor health outcomes can be explained by social determinants of health, including access to healthcare. So we can see here that the uninsurance rate did decrease and plateau from 2013 to 2017, due in part to the Affordable Care Act, but it's clear that there's still gaps with American Indian, Alaskan Natives, Hispanics, and Black populations with the highest rate of uninsured. So I'm going to take a pause here with this presentation and let Dennis, our registered nurse, take over and explain what's been going on at Mercy.
Thank you for that presentation. It's really stunning to see those numbers, and I think we can better understand how they come out in the actions that are taken by decision makers. So this summer, Mercy Hospital, which is owned by Trinity Healthcare, announced that they were going to be closing this spring. And Trinity is a multi-billion-dollar company has hospitals across the country. They're supposedly nonprofit. They supposedly are Catholic, meaning they have Christian values, but they certainly don't reflect them in their activities. Mercy is a sizable hospital. It's like it was mentioned earlier, it's one of the oldest hospitals in Chicago. It's located right at the opening to Bronzeville, which is on Chicago's south side. It serves that community as well as the Chinatown community. So basically, most of their patients are Black and brown people. It's a big hospital. The ER sees about 50,000 people per year. Thousands of babies are born every year at that hospital. And so it was a shame to hear when Trinity announced that they were basically going to close Mercy down. And the reason that they put out is because, well, we can't fund it anymore, we can't afford it anymore. And it wasn't that Mercy was particularly doing bad financially, just wasn't doing good enough for Trinity's supposed nonprofit goals. And Trinity is not just doing this in Chicago, it should be noted. In West Philadelphia, they're also closing another hospital, which is, West Philadelphia, also a Black neighborhood, also called Mercy. Maybe they've got a habit of closing hospitals called Mercy in Black neighborhoods. Also in Holyoke in Massachusetts, they shut down an inpatient psychiatric number of about 100 inpatient psychiatric beds. And so this hospital clearly cares a lot about the bottom line and doesn't really care about people. And this is in the same neighborhood where we've also seen cuts to healthcare. Before I came to Stroger, where I work now part-time, I was working at Provident, which is just down the street from Mercy Hospital. And that hospital system also saw cuts to it because of budget shortfalls. Cook County commissioners voted unanimously to cut the budget of Cook County. And so they reduced the number of inpatient beds at Provident, and they reduced the amount of care, the amount of staff. They laid off doctors and nurses, including myself, from Providence ER. And so it just begs the question, like, where are people supposed to get health care? I mean, my last day that I worked at Provident, I took care of a patient who had been laid off from his job because of the pandemic and was out of his insulin. He couldn't afford it. He just basically went out of it. He was, 40 years old. He thought he could just power through it. I mean, his sugar was in the 800s. He was definitely in DKA. We had to send him to the ICU at County. And this is how most people get healthcare, unfortunately, in our broken system. It's not because they have primary care doctors. They use the ER. They use what's in the neighborhood to help them get access to healthcare. So there are direct impacts on people's health when you cut services, especially in neighborhoods such as they're cutting it. We already know that racism has had a horrible impact on Chicago and has its mark on coronavirus. For example, 70% of deaths in Chicago from coronavirus, or 70% of the deaths from coronavirus in Chicago are by African American people. I mean, that's just outrageous when they make up about 30% of the population. As was said in the previous presentation, the death rate during baby delivery is 3 to 4 times as high for Black moms as it is for white moms. Black babies are twice as likely to die. Colon cancer, African American men are 40% more likely to die from colon cancer than their white counterparts. And none of this has to do with anything that's genetic about your melanin-linked genes to have these diseases. It has to do with a racist system which doesn't provide adequate care to people in this country. And that's what we need to be clear about. Chicago is the unfortunate home of one of the largest life expectancy gaps when it comes to communities. Up in Streeterville, which is right near the Mag Mile, north of the Loop, very rich, very wealthy area. Northwestern Memorial Hospital is housed there. They have the average life expectancy is 90 years old. That's pretty good, Down in Englewood, just 8 miles away, you could literally walk from one neighborhood to the other, a predominantly African-American, much less resourced community, it's 60. So in the third largest city in the richest country in the history of humanity, there's a 30-year life gap. And this is before coronavirus. This is before coronavirus that you have this gap. And so how this wasn't a 3-alarm fire bell ringing in the city saying this is a huge problem, racism is a public health crisis, is astounding. It says something about the priorities of this city and of our society. If people haven't read it already, there's a great book by Dr. David Ansell, who's at Rush. He was at County before, and then I think he was at Sinai. But anyway, it's called The Death Gap. And he describes even in that neighborhood, near where Mercy and Provident are, there is a life expectancy gap just between Hyde Park, which is the home of University of Chicago, an $8 billion endowed university with a huge hospital, all kinds of resources, and Washington Park, which is just the other side of Cottage Grove. You literally lose 14 years off your life, depending what side of that street you were born on. And this is obviously nothing that anyone has control over. You don't control who your parents are, what color their skin is, what kind of economic resources they have, but this is the hand that people get dealt in this city. And so this is an absolute problem, a travesty that they're cutting more of these services in this time. And it's almost astounding how this is all post, the protest movement against racism, against the murder of George Floyd, and the way that racism has marked this country really since its inception, and how little has been done about it, all things considered. And so you can have Mercy just say, oh yeah, we're gonna shut down in the middle of a pandemic that's disproportionately killing African Americans on the South Side. I mean, make it make sense. It is just completely outrageous. And so obviously people in the community didn't want anything to do with it. They were totally opposed to it. They organized and came together. We're talking about unions that represent workers. So like the Teamsters who represent workers at Mercy, National Nurses United, the union that I'm a part of, which doesn't represent nurses there, but see this as an important issue. We see this as an important fight that we want to back. You had Physicians for National Healthcare getting involved, White Coats for Black Lives, the Kenwood Community, Kenwood Oakland Community Organization getting on board. There's all kinds of organizations came together, and we formed the Chicago Health Equity Coalition to fight this closure of Mercy. We've had protests, we've gone on the media, we've talked to politicians. There's several state representatives and politicians who've taken the right side and supported this fight against the closure of Mercy. And so what we have right now, where we're at right now, is that there's a company that's come in and said they're willing to purchase Mercy. And so we'll see how that plays out. The company's called Insight. They are coming out of Michigan. And so they're just starting that process of basically trying to acquire Mercy, and we'll see what happens. But I think the issue is the deeper problems that exist that produce the inequities, the racist inequities that exist in our society are not going to be solved by just handing it over to the company. So I think it's a good thing that we want to make sure that Mercy continues. We want to make sure that there's healthcare for people in that neighborhood. We also, I think, have to address the fundamental problems of our healthcare system, which is that it's completely profit-based. And as we know, when the dollar comes first, everything else is going to come last. And all the people who need the healthcare the most are going to get it the least. And so that's why we have to continue our fight, not just to keep hospitals like Mercy open, but fight for a different kind of healthcare system where everybody has access to healthcare. I mean, it's a complete outrage that in the richest country in the world, we spend more per capita than any other country on healthcare and have some of the worst outcomes, whether it's around high blood pressure, diabetes, asthma, all the handling those diseases, life expectancy. Every mark, this country comes out last when we pay the most. It makes absolutely no sense. It's going to be a tough fight, obviously, because the health insurance company is huge. They've got deep pockets. They have a lot of influence in Washington, D.C. They're not about to go down and just give up a multi-billion dollar money that they've been making over decades. And so it's going to take a massive organization, a massive fight to make that happen. So I really appreciate everyone's participation in this meeting and talking more about how we can win that fight.
Thank you, Dennis. That really makes it very clear the kind of issues that we're working with. As the sign behind you says, racism is very much a public health crisis, but we're not taking public health seriously. And in order to do that, I want to propose a solution for us tonight. So I will go back to our slides. We are a little ahead of ourselves. Okay, so yes, the solution that we propose is bringing universal health care, guaranteed insurance to everyone. It could address issues like the closure of safety net hospitals, but also spark a fundamental transformation in the way that we practice healthcare in this country that I think is absolutely needed to deal with the public health crises of our day and our future. So first of all, I'd like to point out examples in which existing forms of guaranteed coverage do lead to better health outcomes for people of color. So patients in the Veterans Health System enjoy better control of chronic disease with lower rates of heart disease than the general population. What's behind this? I think one very simple answer is that their care is just cheaper. Their medications cost at most $11 a month. They have annual caps on out-of-pocket spending. And it should be no surprise that when you can afford your medicine, you're more likely to take them. In fact, Hispanic VA patients have seen even better rates of taking their medications than white VA patients, which is a reversal of a racial disparity that us doctors care a lot about. I repeat, a reversal of this trend. Usually all of the racial disparities line up with worse outcomes for racial minorities, better outcomes for white patients. But here's an example in which guaranteed cover reverses that. Let's look at another example. For Medicare, Black patients on dialysis do better than they otherwise would. And existing ways to make screening more accessible also reduces death. So let's think about how to take what we've seen of the benefits of existing forms of guaranteed coverage, but make that accessible to everyone. We see the clear benefits of this guaranteed coverage, and we need to make it universal. So, so what we like to call this is improved Medicare for all. we want to propose a plan to cover all Americans from birth to death with healthcare guaranteed by the government that eliminates all out-of-pocket costs. If you ever reconsidered seeing a doctor because of the cost of your copay, we don't want that to be a reason you don't see us or take care of your health. If you feel sick, then you see the doctor. It should be very simple. The graphs right here show the kinds of burden that daily expenses like medical care pose to average Americans. As you can expect, Black and Hispanic Americans, even those with college degrees, are hit much harder by a $400 trip to the emergency room than white people. And this is something that we absolutely need to rally against. We want Medicare for all, so the cost of healthcare isn't a reason that we don't go see the doctor. And as I was saying before, there's a lot that we want to address the lack of clinicians and healthcare facilities in communities of color. When you have a system that is designed around profit, then healthcare resources concentrate in areas where there is a lot of capital and profit, but not in the areas where medical need is the highest. So in order to address this, we want for improved Medicare for all to fund hospitals through a very fundamentally different system. Rather than fee for service, we want to move toward global budgets that can allocate resources based on community needs. So we should really take a step back and understand why is healthcare is so expensive in this country. And that requires us to think a lot about the way that money gets moved around in the healthcare system. Much of our healthcare spending doesn't go toward our health. Insurers, hospitals, and pharmaceutical companies have large operations set up to take a little slice of each healthcare dollar spent. We want to make the system much more streamlined, where if you're paying for healthcare, then it directly goes to your care, paying for your operation, paying for the labor of your healthcare team, rather than funding pharmaceutical ads on TV or the million-dollar salaries of insurance company CEOs. The existing Medicare for All legislation in the US Congress turns this on its head by instead of making clinics and hospitals justify the money they make to insurers, which is usually by performing unnecessary but profitable surgical procedures, hospitals could instead be funded more like schools, where they're given a global budget to spend in a way that addresses the community needs. Hospitals will get the money they need to serve all their patients, rather than favor insured patients while turning away Medicaid or uninsured patients as their lifeline to stay afloat. So let's dig into this issue of the under-resourced facilities and quality of care available to people of color. We want to make our healthcare system work directly for us and address all of our needs. People of color are more likely to die from preventable and treatable illness because the scope of our care is limited. Under improved Medicare for all, everyone will have comprehensive coverage, including access to vision, dental, prescription drugs, mental health, and long-term care. Has anyone asked why our current system treats your teeth and your eyes as if they're luxury products separate from the rest of your body? We think that makes no sense. We need to revamp this healthcare system to make things so much more streamlined. Also, when it comes to research for novel diseases like COVID-19. Currently, our health data is very fragmented, similarly to our entire health system. Think of any time that your care might have been delayed because you had to have your medical records faxed from one facility to another. This makes it very difficult to have any sort of centralized database for health records or health data. With single payer, we could move to a single medical record system, one that isn't designed around profit, but again, around actual medical need. And consider all patients in one unified complete set without this fragmentation. I think that this could have really sped up the level of COVID research that was taking place in the early days of COVID. A lot of the most practice-changing knowledge for combating coronavirus came from countries like Italy and UK, where they do have these centralized databases to study how do our proposed treatments affect the patients that we care for on a population scale. And with that knowledge, then that drove a lot of our clinical changes that have made a big difference in our ability to take care of COVID patients. So improved Medicare for all is an investment in Americans' economic prosperity. At the end of the day, all we're calling for is to make our healthcare system much more efficient and designed around our health needs while not breaking the bank. I imagine for 99% of the people in this audience, if we move to this legislation, you will end up with more money at the end of each year because you won't be paying for copays and premiums any longer, and you'll be able to see any doctor of your choice. Now, the money you save can go towards housing, food, and education, all these other crucial aspects of social determinants of health that we need to address to improve public health for the population. So here are some other benefits of improved Medicare for all. Healthcare won't be tied to your employment anymore. If you are in a job that you hate just because it provides healthcare, you will have a lot more leverage to leave that job and go to a job that lines up more with your skills or your interests rather than being tied down. This lifts the burden for your employers too when they don't have to provide your healthcare. You can choose whichever doctor you like to see. Maybe you've had a primary care doctor that you've developed a relationship with over many years. Now we eliminate the concept of being out of network, where you can't see the doctor that you have been seeing for many years just based on what insurance you have. That makes no sense to us, really. And also this could have lots of downstream benefits for labor unions. A lot of their negotiations are just around providing healthcare benefits to their union beneficiaries. That takes up a lot of organizing energy. If our healthcare was guaranteed, they could channel all that same energy into much larger labor fights for their workers, such as higher wages or safer workplaces. They would be able to devote a lot of these existing energy that goes toward healthcare negotiations toward these other issues. So with all that, we definitely need to take action. We think that Medicare for All is seeing the light of day for once. It is a majority position that is supported by the public, but we need to have the political will to make it happen. And for that, we need you to advocate for improved Medicare for all. Here in Illinois, there are two levels by which to advocate for this. There's the House bill, which was previously HR 1384, but it will be reintroduced in the new Congress and we'll probably have a new number. So in Illinois, one of our longest holdouts has been Mike Quigley in the 5th District. If you can call him and get him on board, that would do wonders for us. At the Senate level, the bill was previously S1129. We need you to call our senators Dick Durbin and Tammy Duckworth to get them to support the Medicare for All Acts. If you just if you called their offices and tell them that you want them to support the Medicare for All Acts, they should know what you're talking about. It has very much been in the news. And also, we want you to support the legislation taking place in the Illinois General Assembly that Representative Flowers on this call has introduced. We think that we should absolutely build a ton of momentum around this issue at the state level as well, to make our overall fights much more organized and strategic. So with that, I will pass it along.
Great. Well, thank you so much to all of our speakers so far. That's been, I think, a pretty troubling portrait, but something that for many of us in healthcare is unfortunately not surprising. But I'm encouraged to see all the folks on this call and to know of all the amazing work that folks are doing to try to make this change. And one of the people doing some of that amazing work is Representative Flowers. So I'm hoping we can hear from you for a bit about your experience in this fight.
Well, first of all, I'm humbled and I just want to say thank you all very much. Looking at you and listening to you reminded me of maybe about 25 years ago when I met Dr. Quinn Young. Have any of you all ever, okay, need I say anymore? So Dr. Quinn Young and I and Nick Scala and Ann Sheets and Sonia Noonberg and Judy Weiss. And, we traveled all over the state, advocating, talking, begging, pleading, trying to educate. Your words was verbatim, probably of what Dr. Quinn Young was doing when he was with Martin Luther King. So this struggle has been going on for a very long time. And quite frankly, it's not getting any better. If anything, it's getting worse. I'm reminded of in 1993, I think it was, when Hillary Clinton tried to put forth something like a single payer health care. And she was just brutally criticized and put down. It was just awful. But everything you guys have said tonight is absolutely correct. When you think about what's happening across this country that you don't see in other countries, as it was stated earlier, other countries, third world countries, are much better off than we are in regards to our access to health care and their life expectancy and their babies, and their maternal health is much better. But yet we are always bragging about the fact that we have the best health care in the world. Well, I don't know what you mean by that, and I don't know who's getting it, because it's surely not us. When I think about the prescription drugs, the prescription drugs is probably made someplace on one of these campuses that get some state and federal funds. But yet the United States pays the most for prescription drugs. Other countries don't. They negotiate their prices down, and the United States sell the same medicine that we use over here. They sell it to other countries for a cheaper price. When I think about how people used to put down Cuba, and how awful Cuba was and how awful Cuba's behind time, but yet the doctors are over here teaching our doctors as well as helping our doctors. And yet the people over there, they're not losing their home, their livelihood, or anything because they cannot afford the cost of care. But the part that always puzzled me the most was insurance companies have a fiduciary responsibility to their shareholders. And so when you think about how can they possibly have our best interests, because every time we get sick and present ourselves to them, that means their stock is going to go down. It reminded me of this book, and I'll share with you before I leave, before it's over tonight. But, and I may mispronounce the last name, but Linda Plano testified in Congress that she caused the death of so many people, patients that she's never seen before, by using a stamp that said, denied, denied, denied. But she got a bonus. And she says she's never been held accountable for what happened. So when you think about our healthcare system, it kind of reminds me when the World Health Organization is purporting always that healthcare should be a right, or healthcare is a right. But as an African-American woman, when I hear that, I'm reminded of affirmative action, how that at one time was a right. But healthcare is no longer, and has not been, a right, just like affirmative action. It's a goal. And it's a goal that we're going to try to achieve, but we've never achieved it because of the institutional racism. I'm reminded of Dr. Sims, who was the author, and he started the gynecologist, and how he used Black women, and how when he was asked, well, the question, well, didn't that hurt? And what happened? He says, oh no, those are Black women. They didn't feel any pain. I had a hearing 2 years ago in I had a hearing in 20 and in 2019. And it was on the maternal mortality and the morbidity, trying to figure out what was going on, what is different than what was going on 30 or 40 years ago, because we were not dying at this higher rate. And doctors from the University of Chicago, University of Illinois, all across the state, they came, they testified that racism, they admitted to the fact that racism played a major part, because they were taught that Black women do not feel the pain. We have a higher propensity for pain. And doctors were taught that African-American women, we don't know what we're talking about. So they really don't see us. They don't pay attention to us. They ignore us. And it has to be about race. It's not about the money, because we do know women of wealthy income, they're dying at a higher rate. We know about what happened with Beyonce and Serena Williams, how if they were not able to advocate for themselves, they would not be here today, and probably not even their babies. So we have to have our voices heard. We can no longer sit back and think someone else is going to raise this issue or continue on this fight for us. When I think about the hospitals and the hospital closing, I remember years ago, probably before any of you all came to the campus, I was over there protesting for an emergency room for adults. And we finally got it. But in the meantime, there were so many people at Providence Hospital. Look how close Providence Hospital. I used to work at Providence Hospital a long time ago as well. And look how close Providence Hospital is to the University of Chicago. Look at the disparities. That's less than a mile away. Look at the disparities. That's unconscionable. When we think about these safety net hospitals, we call them safety nets, but they're really not safety nets, because they don't have all the necessary equipment to save one's life, to give birth. When a woman gives birth, it's not a one size fit all. There's certain hospitals, and the ambulance or either whoever needs to know the nature of her illness. But in this state, and with my bills, I'm trying to even have introduced women of childbearing age, so they could have access to health care. Because oftentimes when these women present themselves to the emergency room for the first time to deliver their babies, the doctors don't know their status, their background, and neither do they, because they've not had the opportunity to see a doctor. And when you think about the social determinants of health, when you think about the government programs, those are the impediments. The government programs are the impediments for us to be able to be successful and have access to healthcare. For those who are employed, as you stated earlier, Dennis, I think that was you that talked about if we had a single payer of healthcare, we wouldn't have to worry about our employees. Well, when I think about all the Caucasian people that had died from opioids, well, I want to take you back to the 90s. A lot of those kids were kids then, and they were placed on some type of drugs because of their learning disability or their behavior. So we had an alphabet of drugs that we would give these kids. And then one day they grew up and we got the Affordable Care Act, and the Affordable Care Act says you can stay on your parents' insurance until the age of 26. Well, when these young adults got to be 26, guess what? Their parents no longer had that insurance, because the Affordable Care Act said you had to get rid of the Cadillac insurance and all kinds of other things. And so now we got them hooked on the drugs when they were children. Now that they're adults, what are they going to do? And then look at the very people that we were supposed to have been trusting and, telling us the truth and giving us the proper information. And, I don't have to tell you that a lot of them was pushing those drugs. They were giving it to the patients. Why? Because of the profit. I tried to introduce a legislation that would prohibit the pharmaceutical companies from walking in the doctor's office, getting their ID number and tracing the ID number with how many prescriptions of that particular company that they're, how many prescriptions is being written. And was not successful with that. And once again, as long as there's a profit to be made, we're going to always have problems. You guys have done a fantastic job of articulating about what a single payer healthcare, that would be a system, what a single payer healthcare system would do. But right now, we're fragmented. If we had a single payer health system, we wouldn't have to worry about the copays, no deductibles, no referrals, no lost referrals, no pre-authorizations, no paperwork. You would have your card, your social security number. You would present yourself. Barack Obama, former president, said, if you like your doctor, you can keep your doctor. Well, that didn't really turn out to be true. But with a single payer, if you like your doctor, you actually can keep your doctor, because those hospitals and doctors will not be able to they will not be doing the same thing that, how can I describe this? The healthcare doctors would be doing something different than the other doctors. If you want a tummy tuck, or a facelift or something like that, you can pay for that. That will still be acceptable and available to you. But healthcare would be free. And when I say free, it will be much less expensive than what you are paying now. Because right now, for those of us who are fortunate enough to have insurance, we do know that a lot of the monies is going to the pockets of the CEOs of the hospitals, as well as the insurance companies. We also know that it's going to the marketing, saying my hospital is better than this hospital. It's going to promote the pharmaceutical or the prescription drugs. If you take this, if you take that, and then the disclaimer at the bottom, if you take it, if you don't have this, this will cause blindness, it will cause a heart attack, that's just unacceptable. So I'll stop for now, and feel free to ask me any questions, and I'll try to do the best I can to answer. But once again, thank you all very much. And I look forward to hearing you in Springfield. I'm so glad to be here tonight, because it's been a lonely fight. If you go back and look over my bills, I've been in office for 36 years. And probably for the last 25 years, I have been introducing some form of healthcare. And of course, Dr. Quinn Young, it's been a while since he left us, but there has not been this movement since his death, and once again, I can't thank you guys enough. I've been on your campus. I've been there to protest a couple times, and I'm a lot older now, but if I can meet you there, that's for sure. Because we are going to have to stop these hospital closing. But the part that really that's annoying to me about these hospitals, it's not these CEOs' private domain. They don't have the right to close these hospitals. And these boards need to understand that they have the power in their hand to tell the CEO, you leave, and leave our property here. Because as you stated, Dennis, how long has these hospitals been around? And it's not fair to take these hospitals. Yes, we do need new hospitals. We do need better equipment, because the equipment that we have in some of these hospitals is old and outdated and may cause more problems. But also, I know some of the new stuff that we're buying, or these hospitals are buying, is really unnecessary, and a lot of doctors really don't know how to use it, and that too is causing the unfortunate death of so many people. And one more thing. There's a doctor on your campus, University of Chicago, Dr. David is his name, and Dr. David was telling me how he thinks that it's very important that doctors learn about the history of America. And maybe then they will become a little bit more sensitized to understanding how government has played a role and how racism has played a role into their thinking. Just like the police officers, if you have never came in contact with a African American person or Asian person, or Indian person before in your life, you've lived in your little enclave, and now all of a sudden you present yourselves and you're frightened because this person is new to you. You don't know what they're going to do. You heard about these types of people. So the first thing you want to do is to, put your guards up, and without thinking that this person is a human being. I've had some interns, a couple of professors down in Carbondale would have their interns to call me. And a couple of them would ask the question, what would you have me to do with my first patient? And I said to those doctors, interns, I said, the first thing I would like for you to do when you walk in the room, I want you to see the person. And then you walk over and you look them in the eyes and you introduce yourself and you tell them your name. And then you take a deeper look at that particular person and try to identify. Look at the glasses, look at the nose, look at the clothes, look at their mannerism, and try to find something about that patient that you can identify with somebody that you care about, and see that person as a person and treat them like a person, and know that there's standards of care. When at the hearings that I had, when I read and heard that these doctors testified that most of these women died from what is it? When you bleed to death, I'm sorry, I'm just having, they
Postpartum hemorrhage.
Hemorrhaging, died from hemorrhaging. How do you do that? There's a standard of care in the hospital that you could judge if a pregnant woman or if a woman that just delivered is hemorrhaging or not. Just use the standard of care. If you have a patient presenting with a heart attack, you have your crash cart, and everything you need is on that crash cart. When a woman presents herself being pregnant, I think there really does need to be a separate entity. This COVID has shown that pregnant women, they're not sick, but we were putting them in a position where they can become sick and even die. So we should have a birthing center or a maternal and child clinic or hospital for the parents to go to in case another COVID come along or any other disease or bacteria. It should be, to me, it should be separate. But anyway, I would like to pause now, and so thank you all very much. Mm-hmm.
Well, thank you so much for that, Representative Flowers, and for your long fight in this. And as you know, a young person coming up in the medical establishment, I'm really honored to be joining the legacy that you and Dr. Young and so many others have laid before. So it's a real privilege to be with you tonight, and I really appreciate your perspective and words. It's really powerful. In our last couple minutes here, I want to open up the floor to questions that folks may have. So please drop them in the chat. You can raise your hands by clicking the participants button, and we also have a couple submitted as well. So if we don't see any coming in right now, I can go ahead and ask. Go ahead and start with one of those. For any of the panelists, how do we get there? What is our best route for passing Medicare for all in the near future, and how do we apply pressure on the new administration to try to get this done while we have Democratic majorities in the House and Senate?
Well, how I think we need to talk about this pandemic, and we know that the reason why we've been isolated because if we go around our loved ones, we may contaminate them. But we also know that most of the people that were dying had pre-existing conditions. And never once throughout this entire year have I heard an outcry for those of you that have pre-existing conditions come to the hospital. Maybe if we were able to treat that pre-existing condition in the first place, maybe so many of them would not have died. And so it just goes to show you that if you think that you're okay because the pandemic had not hit your house, but then you went outside or your loved one went outside. So it's incumbent upon us to say that we're all in this together. This is what Dr. Quinn Young said, everybody in and no one left out. And that's the reason why this pandemic has really exposed the fragmentation of this lack of access to care and how discrimination and racism is going to bring us all down if we don't do something about it quickly. And look at the waste. Look at the waste. Look at how much money we're giving to insurance companies. Just last night, I was at a meeting, and so we went from the HMOs to the MCOs. Now, before the MCOs, people had Medicaid cards, and they can go to any hospital, any doctor. They really had a single payer. They could pick their own doctors and their own hospitals and go where they want to get their prescription drugs. But oh no, this government intervention, they decide to come up with an MCO. And so now, initially, the MCO gets a capitated fee. So you got paid and you never even seen not one patient. And so once again, think about it. This doctor get a capitated fee, he has children that he needs to send to college, and here you come presenting yourself with a cancer. Do you think I'm gonna operate on you? As a matter of fact, that's exactly what they told my brother. Mr. Flowers, you may as well just go home and die because there's no point in us operating on you. Fortunately, my brother did live another 15 years. And so, but if he had to deal with that doctor wanted him to do, he wouldn't have had we wouldn't have had those 15 years together. And, but we have to, when you think about, people want to say, oh, you want socialized medicine. Well, not really. When we bailed out AIG, you guys may be too young to remember, but in the 90s, when we had the crash, we bailed out AIG. We bailed out the car manufacturers. We bailed out banks. We bailed out the Wall Street. Now, let's not tell anybody, but those were taxpayers' dollars. Same principle. We do have a form of a single payer school system. We do have a form of a single payer police department because it's the taxpayers. Our libraries is paid by tax dollars. So why are we trying to make healthcare like, oh, we can't do that? That's a socialism. Oh, really? Well, guess what? We are all going to be looking for some socialism, pandemic, COVID-19 checks in the mails. The businesses, they're going to be looking for it. Everyone is going to be looking for something in the mail because of the taxpayers. And so we have to educate people on what socialism is really all about. And one thing about the wealthy people that got their COVID money the first time around, I can't think of some of the movie stars, but they even got some COVID checks. There was no shame in their game. They kept the money. So it's all about education, and we need to just explain to the people real simply that the way we're doing healthcare now is to all of our detriments. Mm-hmm.
Absolutely. Thank you again, Representative Flowers. It's everybody in and nobody out, and enough of socialism for the wealthy and rugged capitalism for the poor. So as we come to the close of our hour here, I just want to thank all of our speakers again, and I also want to invite all participants here to another talk that we are having on March 25th that will feature Dr. Susan Rogers, who is the president of PNHP and on this call. Thanks for joining, Dr. Rogers. As well as Dr. Peter Gann, who's a member of the Illinois PNHP Steering Committee. And we're going to have a very thought-provoking discussion about the history of the single-payer movement, the ideology and tactics of the movement over the years, what its implications are for the medical hierarchy, and where we go after single payers pass. So we will send out a flyer with the information for that talk with a follow-up email to this. And I just want to thank everybody so much for joining us tonight and for such a lively conversation from our discussants.
Well,
Thanks,
thank
everybody.
you very much. I appreciate you. Thank you for inviting me.
Absolutely. Thanks for joining.